Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and Southwest Telehealth Resource Center, and welcome to today's program. So we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So again, this program is being put on by the Arizona Telemedicine Program, Southwest Telehealth Resource Center. And when you join today, your phone or your computer microphone were muted. We will be using the Q&A which is a chat function for any questions. Please go ahead and use that. You can open that up. It's on the bottom of your screen for any questions. CME credit is only available during the live presentation. There is a post-webinar evaluation, and you will find a code in there to be able to claim your CME credits. You'll just text it in. If you don't have an account with the Cloud CME, don't worry about that. I will have it in a thank you email when we are done on how to get that set up. So this was sent out to all of our participants prior to. I'm not going to read through it, but this is the continuing medical education, the objectives, accreditation statement, and disclosure. And again, the attendance tracking, the code will be in the evaluation, and we will get to that later. Our standard disclaimer. And again, please check our website for upcoming events. And this is the URL for the evaluation. I will put that in the chat a little bit later once we get started. Your opinion is valuable to us. Please be sure to do that evaluation and give us your thoughts on other upcoming subjects that you'd like to hear about. So today we have Drs. Rice and Dr. Daines, who are part of the, are going to be doing a webinar here on PANS and PANDAS. Symptoms, diagnosis, and treatment for rural providers. So without any further ado, I'm going to go ahead and pass this over to Drs. Rice and Dr. Daines. I'm going to go ahead and stop sharing so she can pull up her file. And they will get started and go ahead and continue on with our program. Dr. Rice?
Got it. Thank you, Melanie, and thank you for Melanie and Chris for allowing us to do this. We're very excited to be here and hope to generate some questions and maybe hopefully empower you to care for children.
We see the presenter mode.
You see present. You don't see slideshow? Oh, let me share again.
The presenter mode that shows the next slide coming.
The next slide. Okay, let me try.
There you go. Oh, yes.
Yeah.
Now it should.
Is that good?
There you go. Yep. Perfect.
Okay. Thank you. Awesome. So I put our names up here. This is in order of speaker. So that's Mike and I are co-directors of our Center of Excellence on Childhood Post-Infectious Autoimmune Encephalopathy. Disclosures, Dr. Daines has worked with Octapharma to design and implement an ongoing phase 3 trial of IVIG in the treatment of PANS. And both of us have funding through the Arizona Biomedical Research Center to support all kinds of research, basic, translational, and clinical research. So just to start with telehealth, we in our clinical side, actually on both our clinical and research side, do a lot of use of telemedicine. First of all, Arizona is a rural place, and actually this whole Southwest, you're going to see towards the end where we've seen children from, and we've seen children from all over the country, primarily in Southwest. But it enhances our access to caring for children. It provides continuity of care because it is often very difficult for families to travel far. And so if they're having a very specific question, we can do low stress follow-ups. It empowers families and local providers. We try to very much include all of the providers, if that's a pediatrician, family practice doc, a local psychologist or psychiatrist. We try to include the whole team in care. We work with all people from many, many different disciplines, and telehealth helps us with that. And then we do what we're doing today by providing education and more information about this condition. Oops. So here are the terms that you're going to hear. PANDAS is pediatric autoimmune neuropsychiatric disorders associated with streptococcus. PANS is pediatric acute onset neuropsychiatric syndrome. These two often run together, PANS, PANDAS, PANDAS, PANS. And the difference is that PANDAS starts with a strep infection. It also has one of the primary criteria can be ticks, which is not the case with PANS. But both of them, the bottom line is that both of them start with new onset OCD. PANDAS starts with a strep infection. PANS can start with other infections, including the ones that we see the most are mycoplasma, influenza, and Coxsackie virus, but there are others. And then we have chosen this term to include both of those conditions and including other kids who are just a little fuzzy. And that is childhood post-infectious autoimmune encephalopathy. We're going to start with talking about the condition, and then we'll give you a little bit of information about our program and how we might be able to help and support you. I'm having trouble going the right direction. Sorry. So here's our history. Just thinking about the history of PANS, PANDAS. We have been lucky enough to work with Sue Sweeto, who was a researcher at the NIMH, now recently retired, but still working part-time with this population in a physician network. So the way that Sue became involved is that there was an outbreak of rheumatic fever and Sydenham's chorea in the late 1980s. And what she noted with these children is that there were a lot of children who didn't have rheumatic fever, didn't have full Sydenham's chorea, but they had this abrupt onset of OCD. And she noticed this in prepubertal children. So trying to figure out what this was all about, but it was in the context of another outbreak. And so she initially identified the condition as PANDAS, and then with more work, and we'll show you a little bit about that later, expanded to PANS so that we could include other kinds of infections. We work with a lot of people from all of these different universities and more. And we also have a lot of some philanthropic collaborators who are very, very supportive here in Arizona. That organization is called the PACE Foundation. Some of you may have either never heard of this condition or heard of it as part of a controversy in your training. And these are the two reasons that people have given in the past that this is not real or not fully real. There's all kinds of things that have been said. And the two things that came up were that there wasn't a clear biological explanation. And the second one was that it would lead to overtreatment using antibiotics. And here's our response to the controversy. And this is a very quick, and we could go on. This would be an entire talk. But there are now mouse models, OCD mouse models. So it's interesting that you can have OCD in a mouse. And this has been simulated in those mouse models that there is injury to the blood-brain barrier that is mediated by IL-17. We have seen in multiple studies, a lot of this research comes from here. It also comes from Columbia, UCLA, and Stanford, that if you give serum from these patients, it can cause OCD in mice. There's clinical research that shows that if we image children right after onset, that you can see that there's basal ganglia inflammation actually seen on your MRI. And we've also have people all over the country doing clinical outcomes research, looking at the response to anti-inflammatories and IVIG. I'm going to pass this to Dr. Daines.
So the pathophysiology of this is complicated. This was originally described essentially epidemiologically. The observation that in a group of children that got a specific type of an infection, that they tended to develop this sudden onset OCD. Can I have the next slide? And when we're thinking about autoimmunity in response to strep or in response to anything else, actually, essentially, it's because the immune system is making a mistake. And children's immune systems are particularly prone to this, especially before the age of puberty. We see this in children that get viral infections and then go on to develop autoimmune hemolytic anemia or autoimmune thrombocytopenia. We see this in type 1 diabetes. We see this in many of the conditions that we used to think were strictly autoimmune, but now we understand better that there is a infectious trigger or an infectious incitement of the response that causes them to develop these autoimmune problems. So in Sydenham's chorea and rheumatic fever, we've got our group A strep infection. With usually a serotype of the bacteria that is more prone to inducing these conditions. And then we have susceptible hosts, which are usually, again, younger children or children that are more prone to autoimmunity, who develop a cross-reactive antibody response. This antibody response can lead to either heart inflammation, it can lead to arthritis, it can lead to the choreiform issues, or in PANS and PANDAS, what we're seeing is basal ganglia involvement, which leads to changes in mood, movement, and behavior in these children. Next slide's fine. So they've looked at the impact of strep and strep infection in children across the board. Many of these studies have been done in Europe, where they have extensive databases of children that have come in for strep cultures, and then they know that they were strep positive if they received antibiotics and strep negative if they didn't. And so they know that after streptococcal infections, that there are higher rates of movement issues and higher rates of behavioral problems. And they know that the more frequently children get strep infections, that the more likely these are to occur. Can I go next?
That's next. I'm sorry.
Oh, we are next.
Retrospect. Yeah.
Okay, the Danish study, which is where they took a look at these, again, looking at presumed strep versus presumed not strep, and they saw significant increases in both groups, but even greater in the strep group, with increased OCD and tics, both. So again, showing that mood and behavior and movement are all impacted post-infection. Biomarkers. I would love to have a great biomarker for this disease, but I'm going to be honest, I don't. I'd love to have great biomarkers for depression for kids, but I'll be honest, I don't. There are a lot of diseases out there that we just haven't been able to find or identify a biomarker that is adequate to have extremely high positive and negative predictive value for making a diagnosis. And that means that this is it's a clinical diagnosis in the end that we have to meet to decide whether or not to treat people, rather than one that's driven by biomarkers. There is a biomarker test that's available. It's sometimes called a Cunningham panel. It's a series of 5 autoantibody assessments based on likely targets of brain inflammation. It doesn't have great sensitivity and specificity. It's probably in the mid 70s for both of these, which is probably below what you see in terms of clinical sensitivity and specificity if you have a skilled clinician using appropriate diagnostic criteria. There are a lot of reasons that this can be hard to make a biomarker. One of them is that the targets of the autoantibodies could be a very minor proportion of the cells. It doesn't take very many cells in your brain to be inflamed to cause significant changes in your behavior and movement. One of the cells that they're looking at are the cholinergic intraneurons, which are less than 1% of the cells in the basal ganglia, but if they are inflamed, it can cause significant illness. We have been trying to look at this more broadly, looking at any autoantibodies in kids. And these kids with PANS and PANDAS do have increased autoantibodies, but each one tends to be different. And so it's possible that we'll never get to a place where we can have a good biomarker just because each individual patient may be making a different type of autoantibody that is just impossible to pool together and get good diagnostic sensitivity and specificity. And then the last piece, and Dr. Rice already mentioned this, is IL-17. So IL-17 is a cytokine that can weaken the blood-brain barrier. Antibodies in your blood don't cross into the brain very well in the absence of a inflamed blood-brain barrier. And so it's possible that the reason that we have trouble seeing autoantibodies as a biomarker is because the autoantibodies also require a damaged blood-brain barrier. And what we need to look at is some combination of these two. And technologically, we're just not able to do that at this point. Next. And I'm going to hand it back to Dr. Rice to discuss diagnosis because as an immunologist, I'm not very good at this stuff. So
that's not true. All right. So diagnosis. What we're looking for is a dramatic onset of OCD and or severely restricted food intake. We typically see the restricted food intake as a symptom of OCD. It's interesting. These are not children who have body dysmorphia. They don't have an eating disorder. They're actually afraid that their food is going to kill them, that they're going to choke, that it's poisoned, that there's something wrong with their food that's going to hurt them. So this is the criteria for PANS. I mean, if just flip in PANDAS, if you had OCD and tics, that would be the PANDAS. So very similar. The reference that we have down at the bottom is the reference that most clinics across the country are using for the criteria for this condition. So that's our primary criteria, is dramatic onset of OCD. The second one, the secondary criteria are at least two of that long list. Now, we now look for all of these. We have scales to follow each of these different conditions in our clinic, but you can note that they're harder to manage. They're softer signs, so we try to get reports from teachers or from other people. It's challenging, but we really are looking for that acute onset with the OCD and then the secondary criteria. So the OCD is incredibly striking, and I think as clinicians, if anybody does anything in behavioral health, I think that sometimes there's a mix of what's anxiety, what's OCD, and this is very clear. This is not anxiety, this is OCD. I'll give you, these are some examples of children who we have seen. A 13-year-old girl who burned her clothing if somebody would touch her due to contamination. A 5-year-old girl who thought that her saliva was contaminated and just would stand and let her saliva pool out. A 6-year-old boy who couldn't eat his food because his sister's breath was infectious to him. And so they actually had to take him shopping, put food at night when his sister was asleep, take him with a container, put the food in the container, lock it, And then they would only open it when his sister wasn't around. It was very severe. 12-year-old boy living in Tucson is obsessed, worried that his family will be killed by a snowstorm or a tornado or a flood. But this is in Tucson. And he obsessively would, or compulsively, sorry, you have to have the important thing that we've all learned in this clinic is that the obsession is the thought, and that you actually have to do something. You can't just be worrying about something, which is more of an anxiety. This is with OCD, you have to have the thought as an obsession, and then you have to do something. This is a subtype of OCD called harm, and he was just checking on his family all the time and checking the news all the time. We're looking for movements. So as I said earlier, that this is we think, an inflammation of the basal ganglia. That's where all of this is leading. And what we see is going to be the child that you see on the right. I want to show you first what true chorea looks like. And we have only seen this once. But just so you know what we're trying to separate out, this would be somebody who we would be doing further evaluation for Sydenham's chorea. If I can click on it.
You see how I'm holding my hands? Hold them right there in front of you. Good.
That's great.
You want to turn? You want to turn and look at the sign there? Could you read the sign here on the wall? Turn and face the sign here. Look at the sign.
So she's trying really hard. She can't get her arms out straight, and you see in her face, she has a lot of overflow movements. This is what we commonly see. This is called choreiform movements. And at the beginning of this boy's going to be very solid and straight. But as you keep watching, he's going to start having movements in his fingers. See how hard he's trying very hard to hold still, and it's tough. So that's a common finding that we have on physical exam.
You see how I'm holding?
This is amazing. We get handwriting samples from our patients. This is a young lady who we had been following, and she was doing fantastic. And this was her handwriting on the left. And then she got ill, had a flare, and you see her handwriting on the right. So it is absolutely striking, the difference. We have all kinds of images of little kids drawing pictures of their parents, and then the next day, their parents are a stick. So it's very, very striking, the handwriting changes. Tics, a lot of times, particularly little kids, tics are common. And so there's two parts of this. A lot of times tics just happen. If you go to any kindergarten to third grade classroom, there's going to be 2 or 3 kids there with tics, but usually they just fade away. In this condition, the tics will persist and then go away and then return with a flare. We also have difficulty, particularly with the families, understanding the difference between a habit and a tic. And so we spend a lot of time in clinic talking about that, because we ask families, do they have tics? And typically what they describe to us are habits. So here's some shoulder shrugging tics.
Yeah. Can you tell me about Mardi Gras?
Mardi Gras?
Yeah.
We march.
You marched? Did you have a Mardi Gras parade?
Yeah.
And what happened?
And I had too much fun.
You did?
Yeah.
And what happens at Mardi Gras?
And we stopped and we took our mask off.
You did.
Okay, so that's your vocal tic or your motor tic. The most common ones you're going to see are shoulder shrugs, eye blinking, and facial grimacing. But sometimes kids have really complicated motor tics. This one is going to be a vocal tic that is just a throat clearing, little lump. And a lot of times people think this is why it's so wonderful. We have Dr. Danes in clinic. He's an allergist, and he can help us differentiate what's sniffing from a tic and what's sniffing because you have allergies. So just that little grunt.
Yeah.
The other thing that we see is that frequently children have urinary frequency. These are 6, 7-year-old children who've been toilet trained and dry all night for a couple of years, and all of a sudden they start wetting the bed. And the other side of that is during the day, they will be asking to go to the bathroom every 15 to 20 minutes. And they're embarrassed by it. It's really a challenge for the children. These are conditions that we're looking for. We look for anxiety. We do anxiety scales at every time we see children, and it gives us a good idea of overall how they're functioning. So we look at all of the subsets of anxiety, including panic, generalized anxiety, social anxiety. But the one we see most frequently is separation anxiety, where children can't allow, typically mom, out of their sight. They can't go to school. They can't allow her to go to the bathroom alone. It's really quite striking. ADHD, new onset ADHD, developmental regressions. You can imagine if you had that change in handwriting, you would have some issues in school. We also, the developmental side is sometimes we see neurotypical children develop baby talk or just act a lot more immature than their age or than they used to. I think I'm handing it back to you, Dr. Daines. Mike, you're muted.
Yeah, I'd love to talk about treatment. Treatment's both very easy and very complicated at the same time. So the immunologic part of treatment is pretty simple. If there's an ongoing infection, if this is being caused by strep, this is being caused by mycoplasma, we treat the infection. We want to get rid of whatever the source is of the inflammatory response so that we can stop it. The second thing is we treat the inflammation, and we can only treat inflammation that's present. Obviously, we can't treat it in advance, so we treat the inflammation that is there when we see the kids. Research has shown that the best approach for managing flares in these kids is nonsteroidals, and so we use either naproxen or ibuprofen as our first line treatment. We will also sometimes use anti-inflammatory antibiotics, specifically azithromycin. Azithromycin, independent of its antibiotic effect, has a very strong anti-inflammatory effect, and its side effects are usually very well tolerated by these children. So we will put them on courses of anti-inflammatory antibiotics. In children that need a step up in treatment from that, because of the severity of their illness or because of their partial but incomplete response, we'll consider doing a dose of steroids, sometimes a 5-day run or so, just like we would with an asthmatic, to try to knock the inflammation down. And again, in children that show anti-inflammatory responsiveness, but we are unable to completely control with non-steroidal steroids and antibiotics, sometimes we will move on to immunomodulatory IVIG. IVIG is a human blood product that contains antibodies from about 50,000 donors. By giving very large doses of this, you can potentially block autoantibodies from being able to function. And you can also shut off the IL-17 response that is degrading the function of the blood-brain barrier. Obviously, IVIG has significant cost and potential risk associated with it. And so we only do that in the most severely affected and the ones that don't respond as well to the other treatments. Because this disease has behavioral, psychological, and family components, we try to address the behavioral, psychological, and family components. So there is no one-shot biological fix for this. No matter how well you control the infections and the inflammation, there's always going to be the potential for residual issues that need to be taken care of. And so we strongly recommend that all of our children be engaged in some form of psychological therapy, with consideration of psychiatric care if needed. And we have a BCBA team that works on family accommodations and trying to optimize the family's interactions with the child. I do have down at the bottom, there are many unproven and untested treatments being used. That is very true. There are a lot of people that are very desperate about this, have gone to different corners of the internet and found different potential solutions. I'd be happy to go over these with anyone if there are any questions at the end, but most of them are probably not very effective in taking care of this. So again, the theory we're working with here is we're trying to reduce the inflammation, and that's where we came up with our tiered treatment protocol, which uses antibiotics to treat the infections, the non-steroidal medications to manage the inflammation at baseline, and then stepping up to either prednisone or in probably less than 10% of our cases, moving up to IVIG treatment to manage this condition.
So I think I'll take that back.
I'll take over for the cases.
For the cases. So just to maybe hopefully inspire you, we can give you some situations that are a lot more challenging, but it's really quite gratifying to work in this clinic. This is the child that I described who refused to swallow, eat solid. She lost 15% of her body weight. She was so that's where was her OCD, which also kind of manifested as ARFID, restricted eating. She had severe separation anxiety, horrible skin picking. She thought that was part of her OCD. And we were unable to give her the azithromycin or the naproxen because of her swallowing issues. So we had to get a little creative, and we gave her an IM injection of Decadron. And she went, if you're familiar with a childhood global assessment scale, we do this on every child who we see every time we see them. And 100 is perfect. We never see 90s. Kids always have something. You know, in your 10s, you should be institutionalized because you're really dangerous to yourself or to others. 52 is pretty bad, and 85 is fantastic. I kind of wished I lived at 85 all the time. It's a really good score. And her family felt that she was completely back to normal. Another example, a child, and I gave dates because, and I changed the dates a little bit just so that, you know, there's no identification here, that families will come in to us and say the date and maybe the time of day this happened. Typically within, that's really common. We see that. Sometimes we also say, you know, everybody was really busy, we weren't paying attention, then we just realized that they're a different person. So this boy had OCD with all kinds of different types of OCD going on, really significant new onset tics and handwriting, separation anxiety, and ADHD, all of which were new. He was treated with naproxen and azithromycin. We did actually end up treating him for the tics and for the ADHD. I'm not totally clear if the ADHD was completely new, but we ended up treating him. And again, same situation, parents felt that he was back to normal. I don't know, Mike, if we talked about who's doing this. Well, so I'll start here. This is our history. We are a center of excellence. We were approached in 2015 by some families who asked us to start a center of excellence, but they said you have to do it within a year, which is, for anybody who's tried to do that, is extremely challenging. We worked with Sue Sweeto and some of her colleagues at the NIMH, as well as other sites, particularly Stanford, and to learn and develop the center. And we started seeing patients about a year later in May of 2016. We expanded to a Phoenix area clinic in Mesa. That clinic right now is on pause, but we have great faith that we're going to be able to reopen that again. But the Tucson clinic is still very active. This is our team. Mike and I are the co-directors, so that's why we get to be in bold. Dr. Keela is a basic scientist who works with the microbiome and mouse research. Helena Armija is an immunologist who has several projects working with us. Doctors Gardner and Carr are our psychologists or BCBAs. They're really important in this clinic. And so they, we referenced, I think Dr. Daines referenced a little bit the kind of return to parenting issue. A lot of this is such a frightening condition for families that often they're afraid to parent like they used to parent. And so Dr. Gardner and Dr. Carr help reassure them and get them back on track. Dr. Gishon is a gastroenterologist. We see a lot of children with, we actually, because we do so many upfront evaluations, we end up, as part of this laboratory evaluation, diagnosing children with celiac or other gut issues. And so Dr. Gishon helps us with that. Jessica West actually tells us everybody where to go and what to do. She's amazing. She manages phone calls all week. And actually during this call, I got two emails from her asking for help on some children. Lynette Ortiz is our research director, and Joanne Schultz helps with writing. And we have students, residents, and fellows with us all the time. We fill a conference room with people who are working with us, following along with us, and doing projects with us. They've really done incredible work. One of the most recent things is we had a couple of students work together and put together clinic bags for the patients that were OCD friendly and also engaging, because when kids come to us, they end up staying in clinic for about 4 hours because of all the people that they get to see. And so we've had really great response from that, and that came from the students. This is where we have seen patients. We've actually seen, I'm surprised, we have seen a couple of kids, I think, from Alaska. We've done some telehealth conversations with Alaska because it's so hard for kids to get here. So we've had multiple conversations with their providers in Alaska. But you'll see the bulk of our patients are in Arizona. But then we, more previously, we saw them throughout the country. We had to tampen that back down a bit with the pandemic. We have a registry and a biorepository thanks to the ABRC. So what we do when we see children is we classify them as 1, 2, or 3. We get all of this information. We have 10 pages of information of Jessica, our nurse, compiles all of this information for us, and we have a lot to look at when we go in to see children. And we look for, do they have OCD? We look for what secondary criteria they meet. We look for acuity of onset and an infectious trigger. And we classify them 1, 2, or 3. 1, you meet all criteria. 3, we think you have something completely different. And we see that a lot. This might be kids who've had OCD for a very long time. They just have other issues that this is not the condition that they have. And so we help get them situated with somebody else. And 2s are kids where we're not quite sure. Often, last week we saw a child who had lots of other medical issues that could have been affecting his presentation. And so we encourage the family to go address those things first. We also do see children with autism and other neurodevelopmental disorders. And so sometimes it is more challenging to see this abrupt change. One of the things we've gotten really good at is distinguishing the rigid behaviors of autism versus the OCD behaviors. We have a biorepository and registry, again, thanks to the ABRC, where the registry, we invite participants to help us and share their information. That slide that I showed you with all of the numbers across the country, those are people who have agreed to participate in our registry. There are every once in a while some people who say they do not want to participate. So there's numbers as far as patients we've seen clinically are a little bit higher. And we, as part of the biorepository, are collecting saliva, blood, and stool for studies. And I'm going to give Mike a chance to speak again, talking about research, some more research. Mike, you're muted. Sorry.
So we've been doing research in a few different areas. One of the areas we're looking at is microbiome, because this is an inflammatory disease that's triggered by an infection. One important thing to look at is, are there differences in the bacteria that you're carrying around with you at any given point in time? I don't know if you all know, but the majority of the cells that you have with you are not human cells. The majority of the cells that you carry around every day are the bacteria that are coating your body and in your intestines. So Dr. Keela has been able to take a look at the microbiome in children that are affected or not. In this particular study that we're showing here, it's actually twins, where one twin is affected and the other child is not affected, which is why they're listed as pairs. And what they found is that there's a specific genus of bacteria called Akkermansia. This bacteria has been shown to be protective against autoimmune diseases and other conditions, and it is essentially absent in the children with PANDAS. And then when he expanded this out to look at a broader range of children with PANDAS, as you can see in the third figure over there, it still is dramatically decreased across the board, even when you're not just looking at twins. So I think this shows directions that we can take the research that we're using to try to get to a place where we can find a biomarker or a laboratory test to help us better identify the children that have PANS and PANDAS, rather than just relying on the clinical criteria that we use right now. I don't have much to say about genetics. We have genetic material at this point and have not done the full sequencing or anything. There are many genes in the inflammatory pathways that could be involved in this. And until we get enough subjects to get meaningful statistics, it's going to be hard to do much with just a limited data set. Unfortunately, everybody has mutations if you look hard enough. So we really need to look broadly. One other thing we look at is whether IVIG actually helps. One problem here is that everyone wants to see improvement. And the more you want to see improvement, the more you can convince yourself that there is improvement. And so in our kids that we do put on IVIG, when they're able to, we do a limited neuropsychiatric testing panel both before and after the use of IVIG. This way we can document whether there are statistically and clinically meaningful improvements in the child after treatment using an objective validated testing system. So we've been working with some neuropsychiatrists. We've been able to get this down to about a 2.5-hour test instead of the full 2-day panel that they usually do, so that we can assess whether the IVIG that we give is really helping or not. We find this also helps when we're working with the insurance companies trying to get authorization for it, because it puts up guardrails on the treatment so that it's not an open-ended, indefinite process. We're only going to treat to the point that we demonstrate that we've fixed the kids, basically. We do have a IVIG trial going on right now that is international. There are 4 centers in Europe and I think 8 centers in the United States. looking at clinical responses to IVIG. The initial study that showed that IVIG worked was done in the 1990s. And so this is to update that and hopefully demonstrate that it is adequate improvement for insurance coverage across the board. I'll hand it back to Sydney for the outreach.
So we're trying very hard to do outreach, as you can, that's why we're here today. And we have done in person. Right before the pandemic, we went to North Scottsdale Pediatrics. We've presented at the AAP, medical societies. I have a generic hospital there. So we've done multiple hospital presentations. We have done the, also presented to nurses, the state nurses meeting, which was, if you think about it, we're trying to get to the frontline people who are going to see children, who know the children. So nurses in school, nurses in urgent cares, who will be the ones who are the first patients where parents come in, the first providers who the patients are going to come in and say something weird is going on with my child. We also have developed some physician briefs, which Jessica, our nurse, she will initially make contact with, she's the initial contact with families. And if families say that their doctors would like more information, we send those briefs and share that information. If anybody here would like them, we've had our writer work very hard on making those as useful and clear as we can. And that's it. Thank you very much for having us. And if you have any questions, or please feel free to reach out to us. And I think we'll take questions
in the chat.
Oh, cool.
There is a question in the chat. Yeah, let me find it here.
So
is there a central source? You want to take the question, Dr. Dane?
I'll take the first question. I think it's
okay.
Is there a central source updates clinical evidence publication on the use of IVIG in treatment? I'm seeking this for advocating for insurance coverage for IVIG after trial failure of other standard treatments. So yes, so there is a placebo-controlled trial which compared placebo to plasmapheresis to IVIG that was done in 96 or 98 by Dr. Sweeto, which demonstrated about a 60% improvement in symptoms in both the IVIG and the pheresis group. And then there have been several uncontrolled trials that have demonstrated that there is a clinical response, and that clinical response tends to continue beyond just the first treatment, but for the first 3 or 4 treatments that they're given usually. So I can, if you email me, I can have Jessica, our nurse, send you a kind of the bibliography of the letter.
All right, so she sent her email, but we've got some information. Again, all of the handouts will be listed on our website with the recording as a PDF that you'll be able to access. And let's see what the next question was here. I think they were just a comment on how a highly informative presentation about a greatly misunderstood and often misdiagnosed rare disease. Okay, there's another question on here.
So the question for Angie Rivera is it normal to present tics only during the summertime? We don't typically see just isolated tics. So children usually have something else going on. So we're looking for that associated with an infection, being having something else, and some of those secondary criteria. Yes, for pandas, you could just have tics, but you have to have the strep identified, and then you have to have at least several of the secondary criteria. We have seen kids with just ticks that come and go, and we end up not seeing them in this clinic. We end up seeing them as part of their management of ticks as an isolated condition. For a lot of people, that's really frustrating. The challenge is that ticks are just really, really common in young children. And so sometimes you're just going to have ticks that are ticks. Oh, I'm sorry, you're actually, I didn't keep reading. Also presents separation anxiety and refuses to go to school. That would raise my concern. Yes. So we'd be looking for an infectious trigger. With this child, what we would likely do, and we would share with you, is we would give you our physician brief and have you trial. We have very explicit instructions on how to trial naproxen. And when we do, so we start with naproxen, then we go up to azithromycin, but we use it Monday, Wednesday, Friday for a month because it's so long acting. So if you would like those physician briefs, we can send them to you. And what that is really what we're looking for. And the other thing that we found is that the sooner you treat, the more likely you are to have the outcome that I showed in those two cases. The longer you treat, the less likely that is to happen. When we first started this clinic, we were seeing children who had onset of the condition 5-6 years before we saw them, and we honestly made very little improvement in their condition. So you want to recognize it and treat very quickly. This is somebody who I would probably put on a trial of naproxen, although Mike always tells me I've never seen the child and I'm not treating. And I'm not treating, I'm being cautious. But yeah, we would be happy to send you our information and let you and see if you'd like to treat.
And it looks like there's another comment in there about they heard about the PANDAS clinic and was able to get somebody connected to U of A quickly. All right, it looks like what we've got. Yes, and Angie would like that information, Dr. Rice. I can get you her email address as well.
Awesome. We'll send it on to you, Angie.
Great. All right. So if there's no more questions, again, thank you everybody for joining us today. Thank you, Dr. Rice and Dr. Daines. It's great seeing you again. And the evaluation is up in the background. Please go ahead and fill that out. And if you would like to go ahead and claim your CME credits for today's session, there is a code in there that you'll be able to text in off of your cell phone number. If you don't have that account set, don't worry about it. I will have that information in the email that I will send out a little bit later this afternoon once everything gets put up onto our website. And we're going to give you 7 minutes back to your day today, everybody. We're done just a few minutes early. So again, thank you so much for joining us and have a great rest of your afternoon. And if you have any other questions, you can respond to my email as well. But again, thank you, Dr. Rice and Dr. Daines.
Bye, guys.
Thanks, everyone.